to you to kick things off.
Sure, great, thank you. Thanks everybody for joining us tonight for at least my first medical town hall here. I'm Brian Peterson. I'm the VP of Medical Private Practice and Clinical. I've been in this role for just a few months. I'm just finishing up my 6th year at the University of Iowa Hospitals and Clinics, and I primarily specialize in voice and upper airway, and then head and neck dysphagia, and laryngectomy management and that sort of thing. And so, we're kind of gonna, between myself, Katie, and Ashley tonight, going to kind of tag team our town hall. And for, I guess, if Natalie, if you want to advance the slide. So as you can see, we're going to talk about a couple different topics. And I suppose as we go through, we can kind of each introduce ourselves and jump into things. But as you can see, the purpose of our town hall tonight to discuss different topics related to medical speech language pathology. Obviously, we've been in the world of COVID-19 for quite a while. So I want to, at least touch on how some of those, how things are shifting in the different patient populations that we're seeing with that, reviewing some best practice guidelines for treatment of patients in the medical setting, and then determine other key issues, obviously impacting speech language pathologists in the medical setting. Go ahead and advance, Natalie. So what I was interested in touching on a little bit is the, I know, Aaron, thank you for having your kids weigh in, is the tracheostomy and ventilator dependent population. Working at the U, I do see a lot of these patients, and so they seem, not, I shouldn't say commonplace, but we see a fair amount of them, and so in thinking about it, and how the populations across the state vary, I wanted to kind of touch on some of the issues and propose some, I guess, thought questions and myths, if you will, with regards to the trach and vent population. So if people aren't familiar, and if I should add too, as we're going through, if people have questions or things like that, certainly enter them into the chat box, and or bring them up, and we can certainly address them as they come up. But as most of us may know, tracheostomy is essentially an artificial airway placed into the neck for patients who either have airway compromise due to edema or tumor or a number of different things, subglottic stenosis, that sort of thing, and or having difficulty weaning from the ventilator from an endotracheal intubation. And so one of the things that we deal with a lot at the hospital, obviously in all acute medical settings, is swallowing. And with the bedside, and I will admit, when I first started at the hospital, with our clinical bedside with our trach patients, it wouldn't be unheard of to drop some green dye in our water or ice chips or applesauce or whatever we were giving the patients, and see, if we, and then have the present our trials. And if when we were done, having the nurses deep suction, and if we didn't see green, great. And as we've kind of looked at different things, that may not be the best case. And so one of the thought questions I wanted to bring up was the was whether or not the modified Evans blue dye test, using blue or green dye with the PO materials, is wholly sufficient to assess for aspiration in patients with tracheostomy. And the answer, like most things in the world, are sort of, but I wouldn't say that it is wholly sufficient. There was an article put out by Nancy Swigert in 2003 through ISHA, referencing another article that was stating that this blue dye test actually has a 50% false negative rate. And so kind of chance level for actually being able to detect aspiration. And what this study found was that the blue dye test is probably a little bit more accurate when patients aspirate greater than 10% of a bolus. So greater than trace amount. But much like, you know, our clinical bedside, it doesn't really tell you, if you do see that green dye or that blue dye, it doesn't tell you about the pathophysiology of the swallow. It doesn't tell you why that aspiration happened. Was it on the primary swallow? Was it because of, you know, any number of different things? And also just because we don't see that green dye material after the nurse deep tracheal suctions or what have you, doesn't mean that there's not some material still sitting in the throat that's just waiting to trickle down and be aspirated subsequently. And so, you know, at our facility, you know, and we see a fair number of patients pretty soon after their trach placement. We're really, you know, we'll still see them at the bedside, you know, to assess whether or not they are appropriate for an instrumental assessment, and really to just kind of get a sense of, do they have a pharyngeal swallow, or is it overt to the point that, you know, it's right away that we're seeing a cough response, or are we seeing green dye coming from the trach and there's no cough response, and that sort of thing. And so, you know, it's really important and imperative to have that instrumental visualization for these patients with the tracheostomy, so that, you know, we can really most effectively assess their swallow function. I'm curious if there's anybody on the call or on the meeting that you know, has a different practice or a different you know, that you, as soon as you see a trach patient or a consult for a trach patient coming up, that you're right away going to an instrumental, or just if there's anybody that has anything to offer as far as that, you know, kind of first thought question is concerned.
Brian, I know at the hospital here in Des Moines at Select Specialty, the speech is kind of trying to move away from the blue dye or the green dye test. Our respiratory therapists, however, are really big fans of it, which is kind of interesting. They want us to, you know, if we start trials with anybody, they want us to use the food coloring. They want to suction them immediately and see anything. And we've, you know, we've done a lot of education about, you know, well, it's not always the most accurate, but they're really gung ho about it. They really like it. So we're starting to move away from it a little bit, but we actually have other disciplines who are kind of big fans at the moment. And I go back and forth with it, because I agree, you can't always see what you need to see. There's plenty of times I've seen no material within, you know, the inner cannula or anything, and or no cough, and then we take them down for an MBS, and they're, you know, it's frank silent aspiration all over the place, and we never saw it, you know, come out of the trach. So it's can be a helpful indicator if you see it, but there's definitely no guarantee that you're going to see it.
Right. And that's you know, and that's an important distinction to make, that, you know, sure, on these couple of trials, you know, maybe you don't see anything or you don't get it on suction, but it, you know, that doesn't mean you're getting an accurate picture of everything that's going on.
I was just going to share that when I worked in the hospital, you know, we would just most often have the patients go have a modified barium swallow study. We didn't have fees at the facility where I was at. But then I had a family member that had a tracheostomy, and they were in a skilled nursing facility, and I was suddenly on the other side of everything. I was the speech pathologist family member, and I remember they were doing PO trials just to kind of see how to, if he was ready for some PO. And I remember thinking, you know, I know that the blue dye test wouldn't be optimal, but I felt like having that would be maybe better than not having anything. They were just doing blind trials and sort of basing it on any overt signs or symptoms. So that kind of changed my view, because I was sort of opposed for the most part to doing a blue dye. But I thought in that circumstance, you have an access to a tube right there. They weren't able to get an instrumental. So anyway, it was just a interesting personal experience to see things from the other side.
Mm-hmm. Yeah, and I think that, you know, I agree that having something, you know, is that you know, there, what did I say, 50% false. So there's a chance that, you know, if you're not seeing any overt signs, or you're not seeing anything from the inner cannula, that everything is going okay. And so it, you know, I agree that having something is better than having nothing. Anything else that anyone wanted to add about that just thought question? Okay, on to my next thought question that I had. That actually is something that that just kind of came up at our facility here lately. Natalie, you can go back to we'll just stay on that screen. Thank you. Does a patient that has a tracheostomy, do they have to have an uncuffed tracheostomy tube in order to be fitted and use appropriately a passing mirror valve?
Well, it can be deflated, right?
Correct.
So it could be cuffed or uncuffed.
Right. So yeah. So you know, the answer to that is no. A patient doesn't have to have an uncuffed tracheostomy tube in order to use a passing mirror valve. But yes, the cuff has to be deflated, and you know, they have to demonstrate that they can pass air through the upper airway with digital occlusion, and be able to tolerate things like that. But yeah, so we had a situation at the hospital where, long story short, unknowingly a medical team member put a passing mirror valve on an inflated cuff trach, and that caused some significant difficulties and problems. And so then for a short period of time, a lot of the ODA residents were very concerned about consulting us for passing mirror valve evaluations, because the pendulum had kind of swung all the way to the other direction, where they wanted to wait until they could transition these patients to an uncuffed trach before they were consulting us. And so, you know, it took a little bit of re-educating, you know, to get them comfortable again with consulting us on patients that have had cuffed trachs. With anybody who's on the call that works with patients with tracheostomy tubes, you know, what sort of things do you do at your facility that kind of either lets the medical team know that, hey, this patient has a cuffed trach, an uncuffed trach? You know, what sorts of things do you use?
When I worked in acute care, we would always use those stickers that came with the passing mirror valves and put them just on the leader. And then it also came with like a sign in the package, and we would always put those up like right by the patient's head. That way you're not gonna miss it, hopefully.
Right. Yeah. We're fortunate. I mean, we have the little monitors that can be brought, you know, typically right over the patient's head, like especially if they're in the ICU, and we typically tape it to them. And we'll also use those little kind of foldable stickers. And obviously then, you know, I guess the thing that I always look for when I'm going into the room is, first of all, is there a pilot balloon which would tell me that this is a cuffed trach, and is it fully deflated? And if it's not fully deflated, I'll find the RT or the nurse and have them deflate it, so that way we can confirm, okay, we're ready to go. We're in the situation we need to be. Let's see. So as far as training and that is concerned, when we were kind of planning for this, we were talking about obviously the importance of kind of advocating for our patients, advocating for the patients that have trachs and are vent dependent, and there's a couple, there's a lot of trach related CEU webinars on speechpathology.com, MedBridge, Northern Speech, passingmirror.com. All of them have some really good resources on there to look at, to kind of educate oneself about those things. The other thing I wanted to cycle back to, because I know my first two thought questions were on trachs specifically, but one thing, the other thought question that I had that I wanted to kind of pose was, can patients who are vent dependent use their voice to communicate? And for the sake of argument, let's assume that they have intact vocal fold mobility. There's no, paralysis, that sort of thing.
And we could use an inline speaking valve, right, Brian?
They can. Perfect. So that there are certain requirements that specifications that a patient has to meet in order to potentially use an inline speaking valve. But between speech pathology and respiratory therapy, they can kind of coordinate so that the respiratory therapists can do all their things to the vent to make it so that the patient can that they can hook that inline in. But it hooks right into the extension tubing of the vent and functions essentially like a normal passing mirror speaking valve would. And it's been really cool. We had a colleague come on about 2 years ago who had a lot of experience in this inline passing mirror valve world. And since that time, I've been able to assist and participate in probably about half a dozen inline speaking valve evaluations. And it's been really cool to see these patients who haven't heard their own voice in years, maybe, to pop that in, and they're able to communicate. They're able to call their family. They're able to, have these conversations over the phone with family members that they haven't talked to, communicated with verbally in so long. And so, that's another kind of area of our field that's maybe a little bit less known, but still, as viable and important as any other. So, any questions from anybody on the call that you have about just kind of the trach and or vent population that we can touch on?
I had one question, Brian. What do you think our role is in decisions for like capping, downsizing, decannulation, those kind of things?
Sure. So as far as capping and decannulation, I think that I see those more as kind of on the medical surgical decision-making tree, that they've made a decision based on the integrity of a patient's airway, their ability to manage their breathing, that they've needed the trach in the first place. As far as downsizing, that sort of thing, there are some situations where a trach, the trach size that's in a patient's trachea is too big, that they're not able to pass air around it. And so you know, when you do the digital occlusion, you have a lot of buildup of air and then backflow when you release. And so there are times where we will do our evaluation, we'll identify that this patient's perhaps in an 8 Shiley, which is a fairly big trach, and that will, you know, they're not able to achieve voicing or airflow around. And so we'll say to the medical team, you know, like, I think this patient might be appropriate, but we need to get a smaller trach in there to really tell if they're going to be able to tolerate, you know, a speaking valve of any kind. And so, you know, and there are some times where the docs will say, the respiratory status is still a little, you know, kind of up and down. We're going to wait on downsizing, but we'll let you know. And so then, you know, so while it's not our decision, in my opinion, it's not our decision to say, no, this patient needs to be downsized. It certainly can help get the ball rolling on passing mirror valve tolerance. Any other questions or thoughts that I can address with this right now? Cool. So I will pass the ball to Ashley, and then she can talk.
Sounds great. I am Ashley Laudick. I am your president-elect for ISHA. Been doing this for about 6 weeks or so, so I'm really excited. Also my first town hall. Glad to see so many people came and to get more information to that today. Natalie, do you want to switch to the next slide for me? The hot topic in the world, everything. I just want to talk a little bit tonight about what we're seeing now that we're having some folks with COVID recovery, you know, and post-acute care, skilled nursing, maybe outpatient settings. And I really want to hear from you guys what you're seeing and what concerns you have about all of these, you know, post-COVID symptoms and things that we hear a lot about. So I'm just going to kind of go through the list a little bit of things that I've been seeing a lot, or that there's been a little bit of research about. Again, we're right in the middle of all of this, so all of this is really new. So much of this is, you know, anecdotal information, but we're really looking to see, you know, what kind of patterns emerge, what are the long-term effects of COVID that we're going to be seeing, and especially how this is going to impact our profession in the medical setting. We have COVID's been one of those diseases that just seems like it hits every single thing that speech pathologists tend to work on and look at. So these are just kind of a couple. This kind of post-COVID confusion, delirium, and encephalopathy. I know I work at LTAC here in Des Moines, and I know we're seeing a lot of you know, disorientation with these folks, even if they weren't on the ventilator. So it's, you know, this disorientation, you know, poor memory, poor attention, almost like brain injury type symptoms. Been really interesting and strange. And unlike most encephalopathies, it really doesn't seem like it's resolving like you might expect it to right away, or even within like a couple of days or weeks. It really seems like we're seeing some long-term effects with that. Early intervention with stuff like this is really important. It's really hard to advance to get them up and moving in the hospital and post-acute care if they're super confused or combative. But getting speech involved early to work on that, you know, that confusion, that reorientation, I think is going to be really important. That way we can, you know, advance in all areas of care, PT, OT. Just hard to get them to do those swallow exercises if, you know, they can't tell you what 2 + 2 is. So really important to kind of start key interventions and starting early with those people. Dysphagia, that's been a huge one. Swallowing has been an enormous problem with these COVID recovery folks. There's a lot of different reasons for dysphagia. I'm going to cover a lot of them. Dysphagia in general is kind of my bread and butter, we'll say. It's sort of what I really care about. I won't say the most, but what I'm pretty invested in. I provide mobile fee services. I do acute care or post-acute care in skilled nursing and LTAC. I'm very, very, very big believer in instrumentation for everybody with dysphagia. So get used to hearing me say that a lot. So you're seeing dysphagia with folks who've been intubated for long periods of time with this COVID. If we all know the longer you've been intubated, the more likely you are to have a dysphagia or difficulty swallowing. You have this disuse atrophy. You know, kind of the standard is greater than 48 hours. So of course that varies a little bit. And we're seeing folks who've been intubated with endotracheal tubes for 2 to 4 weeks at a time, if not longer, before a trach is placed or before they're ready to be extubated. I think what we're seeing a lot is COVID recovery is really up and down. They might be fine for a couple of days, and then they're like, okay, we're going to extubate you, and then maybe they're extubated for a day or two, and then they need to be re-intubated. So we're seeing a lot of multiple re-intubations, which can cause laryngeal trauma, vocal fold paralysis, paresis, granulomas, edema, swelling, just general discomfort. And then we're not we're not talking, we're not using those muscles, and so they're not being used. And so you're going to see some of the muscle loss, that muscle atrophy in those patients. Breathing, swallowing coordination, we all know how important that is. Breathing's going to trump swallowing every single time. So if we want to get these people eating and drinking safely, that coordination's got to be correct. I know I've seen a lot of folks who their actual swallow is fine, but their respiratory rate is 40 breaths a minute on 10 liters of aerosol face mask or hyponasal cannula and 50% FiO2. Like they're just really, really having a lot of respiratory needs. And until we can get the respiratory part kind of in line and coordinated with the swallowing, eating and drinking are going to be pretty risky. And we need instrumentation to be able to see, exactly how risky that's going to be. Seeing folks get short of breath, even with just mastication. Maybe they tend to hold their breath while they're chewing and swallowing. Again, we don't know until we get our instrumentation in there. So that's going to be really important. And then I know we've seen more people moving to, skilled level of care, home health level of care, without imaging in the hospital because of COVID precautions. I know some places are doing instrumentation on COVID positive folks, which is great, and we're doing it safely. Some places aren't, and so it really kind of depends where you're at and where your patient came from, whether they had that access to that really important instrumentation before coming to see you in those other levels of care. Again, we kind of talked about neurologic deficit, lots of changes in cognition, like we said, with the post-COVID encephalopathy. I've seen a couple of folks who are now presenting with like expressive aphasias or global aphasias, but with no, they've had brain imaging, but there's no infarct, there's no bleeds. We're like, where is this coming from? It's so weird. It's like a big mystery. I've seen post-COVID folks with no upper extremity movement. They present almost like quadriparesis, but they, again, on neural imaging, there's no reason for it. So it's very, very weird. There's a lot of strange things that are going on with COVID that speech really needs to address. And then again, this post-intubation injury we sort of talked about, kind of mentioned the lengthy intubation times, the again, laryngeal trauma, vocal fold paralysis, paresis, granulomas, that kind of thing. And then prone positioning. I think we've all heard a lot about this. It's, we're putting folks on their stomach so that their lungs can inflate, posteriorly a bit better. But that's also going to put you at greater risk for, again, vocal fold injury, airway injury. There's some research out there saying it's less good for mucus clearance. Oral care is not as good in this particular position. Facial injury is more likely to happen. You can imagine when you're turning somebody, over completely, everything is going to shift in there. And so that's something for us to be aware of when we're getting these folks. It's not enough for them to have just been extubated and now they're breathing on their own. There could be these long-term injuries that are impacting their swallowing abilities that we need to be aware of. And then also the increased prevalence of with GERD, with the nasogastric tube. You're on sedation meds, paralytic drugs, and all of that disuse can really mess with your swallow function. So for many, many reasons, how we just listed, speech really, really needs to be involved and look at a really close look at their medical history. We want to be looking at, were they intubated? How long were they intubated? What position were they intubated in? Did they get imaging? What exactly did our imaging show? What's the respiratory status? Do they desat, into the low 90s, 80s, 70s? I had somebody go down to the 50s a couple of weeks ago with like a single sip of water. We need to be aware of all of these things. But I really want to hear from you guys. What are you seeing in maybe post-acute care settings as far as COVID stuff goes? Anyone?
I mean, I've seen, just talking in the different facilities that I go in, a lot of people say that people with dementia, it kind of accelerated, maybe it was mild and now it's severe. And it just seemed like that happened overnight.
Mm-hmm. I've heard that too. It has hit our dementia folks so hard. A lot of them. I had one yesterday, suddenly presenting as globally aphasic after, she was everybody's favorite and would talk to everybody and the nurses and how are you today? And then suddenly, like you said, just literally overnight, she's nonverbal. She's not talking. She isn't doing any of these things. They wondered if she'd had like some vocal cord paralysis or anything. We did a FEES on her. She didn't. But it's very weird. It's very strange. I'm really anxious to see what happens as we get more research and find out more about what's going on with these folks.
I've had several people. So we have like a post-COVID clinic that one of our pulmonologists has set up. And I've gotten, a few like vocal cord dysfunction, episodic laryngeal breathing difficulty type consults because, their lung function is okay, but they're still having these breathing difficulties. And I haven't so much seen that it's so much like the laryngospasm type vocal cord dysfunction, but it's just like their breathing pattern is just off. Like I imagine it's, that, for however long you're working so hard to get breaths in and out in general, that concept of the diaphragmatic breathing, lower focus of breathing is just you're so far left of center that's a big challenge. And I think, these people are months and months and months out from their COVID diagnosis, but they're just still having this messed up breathing pattern, which is interesting.
Yeah, it's that breathing pattern. I know exactly what you're talking about. It is almost like they learn to compensate, and then now this is just their new normal. This is just how they breathe now, and they really almost seem like they need to relearn how to, just like you said, kind of how to do it correctly, or more efficiently, and make it safer for them to eat and drink.
Right.
Yeah.
That's really interesting. I just saw I did outpatient in the home with this guy that's kind of a COVID long hauler, and he breathes so fast, like you were saying. And we've been working to try to slow him down. Like he wears a pulse ox almost all day long because he's so anxious that he can't breathe, but it's always fine.
Right.
That's really interesting. Yeah, I want to know more. It makes me want to go hang out with my RTs all day and be like, explain this to me because I don't understand. We need to make it better. How do we make them breathe better? But again, like I said, if we don't have that breathing system under control, the swallowing system is going to be wonky and it's going to put folks at risk. So that's a big one. Do we have anybody in like skilled nursing who's seeing this kind of stuff, or outpatient or anything?
So, Ashley, my name's Matt Easley, and I'm a speech therapist and outpatient with Life, and I'm in Coralville at our outpatient clinic, and we are starting to see more people coming in to see us who have had more of like a mild case of COVID, but are presenting kind of as those COVID long haulers, and they're actually, what we're finding is that they're presenting a lot like some of our post-concussive folks that we see, in terms of, quote, brain fog, easily fatigued, testable, measurable deficits in attention, that have been really interesting. So we're just kind of starting to figure that out, and can we teach strategies? Can we do some cognitive, compensation and rehabilitation for those deficits?
That's really interesting, Matt. Thanks for sharing that. Yeah, I just think this is going to keep affecting all levels of care for probably quite some time. I hope that we find out more, and I'm curious, share with us, what can we do to, as ISHA, as part of the board, is there a way that we can help support these people, or you, as the ones treating them, to put together what evidence we have to, give you ideas to bounce things off of. You think this might work, if there's something that you feel like you could benefit from ISHA as a resource, we'd like to hear about it. Anybody have any questions or other comments about the COVID recovery? All right, well then, Miss Katie, I will pass it on to you.
Okay, thanks, Ashley. So my name is Katie Decker. I'm the Vice President for Continuing Education for ISHA. I've been in this role for about a year and a half. So this will be coming up on my second year. I do mobile fees. I own and operate a mobile fees company here in Iowa called Midwest Dysphagia Diagnostics. And then I also dabble in a little bit everything on the side. So Natalie, if you wanted to go to the next slide, please. Thank you. So I was just going to talk about swallow instrumentation, and just kind of talk about some the access and quality. So kind of talking about the access, some things that I've noticed is that with COVID, access has been a lot more difficult, whether the patients aren't being sent out, no one's being let in, if they're not doing the evaluations at all on COVID positive patients. That's definitely been something that we've been working through. And so just to know that you can do fees or modified barium swallow studies on COVID positive patients, and, just to kind of advocate for that to be done safely. Let's see, some barriers maybe in acute care. You hear sometimes like, oh, this person came without a swallow study, but in acute care, maybe the person was not appropriate the whole time, and then all of a sudden they discharged. Maybe the person had other tests that were being run that were deemed more important than your swallow test, and then that was it, and then they were gone, and things like that. So definitely some barriers that might be there, that we can definitely understand. And then just talking about like the providers, some providers maybe don't see the justification for them. Maybe the facility itself doesn't, maybe talking more about post-acute facilities, doesn't see that the cost is worth it for the patient. So I'm seeing that there's patients that are being treated without any imaging. So the first kind of discussion I wanted to talk about is that I would put forth that if you have a patient that you think has pharyngeal dysphagia and you cannot get an instrumental evaluation done for whatever reason, should you even treat that patient? I would say no. Any thoughts?
Kate, do you want to explain your reasoning and then I'll fight you on it?
Okay.
I'll just, when I say fight you, I'll play devil's advocate.
Yeah. So my reasoning is that you don't know if they even need treatment. You don't know what is happening. You know, you might think it's residue or it's timing. We have no idea without instrumentation. You might be recommending strategies that make the swallow worse. You might be recommending exercises that make the swallow worse.
Katie, what if we just put them on a honey and puree diet just in case, just for safety?
Mhm.
Would that be, could we just do that and then watch them eat?
No. No. So we know that one, honey thick liquids, you should never put a patient on honey thick liquids. They're more likely to get pneumonia on honey thick liquids than they are aspirating massive amounts of thin liquids because of dehydration and the thickener itself and all these other things that we know. With pureed diets, you have to be so careful with those because the protein content is so much lower. Not to mention quality of life. I guarantee I will never be on honey thick liquids and pureed solids.
You're all witnesses. All right. So what if our facility says you have to treat them no matter what and you're still not going to get an instrumental? What options do you have?
I know that that's not like a good option, but I think we just need to provide education. I mean, ethically, we shouldn't be providing treatment without, if it's just an oral dysphagia, fine, yeah, that's something that we can do because we can see it. But pharyngeal, I mean, how are you justifying the charges that you're putting forth to Medicare if you don't know what you're doing is effective? That would be
I
my.
totally agree with you. I'm just being a pain. But
I know.
they're really common issues that we keep running into, don't we? Because Katie and I, we both do mobile fees, and so we see this all the time. It's you had to fight tooth and nail just to, get the instrumentation in the first place. And then it's almost worse if nothing's wrong because then, well, they were fine in the first place, so you didn't need it. So we're not going to do it next time. It's almost one of those vicious type cycles, but we truly cannot diagnose pharyngeal dysphagia at the bedside. We cannot do it. We do not have the x-ray vision. We're all wonderful, talented, exceptional, extraordinary people, and none of us can do this at the bedside. Is exactly like a neurologist trying to diagnose a tumor without an MRI. It is exactly the same thing. There is no difference. And I clearly feel very passionate about this. So I'm sorry, Katie.
No, you're fine, Ashley. I was banking on you joining in. I think, as a profession, we have done ourselves a great disservice by allowing ourselves to treat without instrumentation because now physicians are used to it, facilities are used to it, and we have to almost uneducate and then re-educate. So I think until we band together and say, you know what, we're not going to do this anymore, it's not going to change. And it needs to.
Preach.
Because I've run across when I've asked for it and they're like, well, the last girl didn't need one. Why are you so much worse at this? And that's their understanding that I need an instrumental because I'm really bad at my job. So we need to educate that. No, we just, no one would know. So.
In one would argue I'm actually better at my job because I understand the limitations of what I can do just with my eyeballs and my fingers on a patient's neck.
Right.
What are your thoughts, feelings, positions as far as like diet upgrades and that sort of thing without re-instrumentation?
I think that's a really patient specific thing. I would have a hard time generalizing it. I would say in general, if you know what the deficits are and you're treating those deficits and you can somehow see an improvement in that specific deficit, whether it's, using a compensation or something like that, then I mean, I think it could be fine. Ashley, what do you think?
No, I agree with you. We might see, I think a good example would be, I had somebody yesterday who could swallow fine with nectar thick liquids, but aspirated thin. But when we used a chin tuck, there was no aspiration of thin, but he was a little bit cognitively impaired. So he needed training to learn how to do the chin tuck. So what we did, we left him on nectar, worked with the facility speech pathologist to train that chin tuck. And then once he was able to do that consistently and independently, we were able to upgrade to thin liquids safely. So I think in like a case like that, I think you're in good hands. I think anytime you've got, silent aspiration with, limited to no success with compensatory strategies, and maybe you're just going to put them on a regimented intense swallow rehab program. I think that in those cases, re-instrumentation is certainly necessary, to see what type of progress you've made by doing that rehabilitative program.
The one thing I would worry about with just upgrading solids is airway obstruction. If you have a patient that's at risk for that, and maybe they eat in their room because it's COVID now or whatever, that will kill somebody immediately. So that is something that I would definitely, if that patient is at risk for that, then I would not upgrade without imaging, just because I would be nervous about that.
Mhm.
I would totally agree with that statement, Katie.
Is there any other questions or thoughts about that point? Or those points? And, I would just add that, as being on the ISHA board, I'm sure I can speak for Brian and Ashley that all of us would be more than happy to provide education materials or, different things that you might need if you are running into difficulty. I'm sure that we would all be more than happy to do that.
Yes, please. Feel free to
And we have a lot. So
I'll take every single one of your emails and send you stuff, because
yeah, we won't stop sending you things then.
It'll never end. I do want to say this is not a slam in any way, because I love living in Iowa, and I think despite all of our challenges this last year, we live in one of the best places in the world. But as far as instrumentation use in post-acute care, and sometimes even in acute care, to my understanding, we're far, far below the national average. Far, far below. We are not using it nearly as much as the surrounding states, as states to the east and the west of us. Iowa, we're behind. Honestly, we're behind. I know it's Midwest, we're always behind, but we're really behind in doing best practice and swallow instrumentation. If you guys are ISHA members, I'm going to be around for quite some time. I'm president-elect. I'm going to be president in 2 years. I'll be post-president in 4 years. You're going to see a lot of me, and I'm going to keep piping this horn for as long as I possibly can while I've got a platform. So get used to it now. But we have to do better. And when we know better, we do better. So I'm going to be a big proponent of that for everybody.
Yeah, that's great, Ashley. Anything else, or I can move on to the quality part here just briefly. So just thinking about what needs to go in a report, I think that people have different writing styles. People have different maybe flow sheets that they're forced to use with their EMR and things like that. And so, definitely taking that into consideration, that sometimes those things are limited or they don't print out right and things like that. But what I would say is, we need the number, the volume, and the consistency of the trials. So, instead of just saying 3 trials within liquid, well, was it a teaspoon? Was it a cup sip? Was it consecutive? Those kind of things. I think that really makes a difference. obviously presence or absence of penetration aspiration, response to the aspiration event, like did they cough? Did they do anything? Did they have no idea about it? Presence, location, and severity of residue. And then the response to that, did they know it was there? Did they swallow again? When they swallowed, did it clear? What strategies did they use to clear that residue if they were aware of it? The big one is the physiologic deficit. So like the why. So like they aspirated, great. Why? Because that's the meat of the report. That's what we need in order to treat, because if you just say, well, they aspirated thin liquids, I don't know how to fix that, but if you say, oh, their laryngeal closure was incomplete. Oh, okay. Well, I know how to fix that, and then if you tried strategies, and then I always think it's kind of nice to provide some recommendations too, for what you would recommend based on what you saw. So what do you guys think? What would you take away? What would you add? Agree, disagree?
I agree. We got to have those physiological deficits. I know I see a lot of reports that just have, aspiration, thin liquids, recommend nectar thick. We need more information because there's 100 different ways or 100 different reasons why you might aspirate. And if we don't know why, then we're going to end up throwing, okay, do this exercise, this exercise, this exercise. We have no idea if those are helpful or if it was a timing issue and their strength is fine and then we just wasted all of this time.
Right.
So yeah, the why, we need the physiology. And if you aren't sure of the why, if you're doing swallow studies and you're like, you know what, I know they aspirated, I know it was a lot, I don't really know why, then we can do, there's so much great continuing ed out there about swallow deficits and physiology and MBS-IMP and tons of these courses, and there's lots and lots and lots of things that you can do to educate yourself. And it's okay if you don't know the answer. I think we think that we're supposed to know everything right off the bat, and that if we don't know the why, they're like, oh, nobody can know that I don't know, this is bad. But it's okay if you don't know. It's okay. Then we just got to find out why. Yeah, Michelle, you're exactly right. Yeah, what was the point of the instrumental if we don't know the why? How did that help us at all? Yeah.
Yeah. Darcy, did you have something to add?
Well, I was just curious, first, if how many people were using the MBS-IMP, if they were doing video swallow studies. And then I was trying to think of, is there anything that's sort of reaching an equivalent that you're using with your fees, where you have sort of a standardized format? I was just curious about that.
Well, I can talk about the fees part. So for the fees evaluations that I do, it's not like a written up MBS-IMP, but it is a standardized protocol that I do with every patient as long as it's safe and appropriate. And then we use rating scales. So there's basically a penetration aspiration scale for fees. There's a residue rating scale for fees. A reflux scale for fees. And then, I always comment on, the physiological deficits. So it's kind of yes and no. I don't know what you guys do, Ashley. I'm sure you guys have something similar.
Yeah, we do something very, so we use the, there isn't, MBS-IMP is really, I haven't taken the course because I don't do modifieds. Brian, I know you talked about that you have. MBS-IMP is like, super, there's a research, the big research article, and very regimented and things. There's nothing quite like that for fees yet that I know of, but we do a pretty regular protocol, as far as for our fees exams, the same, number of trials in the same order of consistency, just again for consistency's sake, so that you're, when you do a repeat study, it's not a totally different study. You're able to compare swallow to swallow like you were before. But again, we use, penetration aspiration scale. We actually have we use the DOS severity scale. We use the Murray secretion rating scale, as much, evidence-based stuff as we possibly can to fit on these reports. We definitely do all of that. And again, we're very big on, I have a great template for saw this means this deficit, saw this means this physiologic deficit, saw this means this one. So, and of course that blurs every now and then depending on the patient, but, it's physiology is the whole point. Physiology, anatomy, that's the whole point of these studies. It's not about the aspiration, it's really about the why. So yeah. Does that help, Darcy?
I think I've heard some rumblings from some other fees providers around the country that that is something that they want to develop and kind of coordinate. It was something that we were going to work on, and then COVID happened. Just because with the fees, we just can have such a more robust study because we're not limited by the radiation time. Like with the MBS IMP, I think that's wonderful because it gives you something that you can really get a lot of trials and get the information that you need in that 3-4 minutes or whatever you're given.
Yeah, and I did the MBS IMP training, and thought that it really kind of forces you to concentrate on the why. It really makes you figure out on the why this is happening, and you also you can't really fake your way through it, like with some with some things, you're not necessarily everything, but with some webinars or CEU things, you can kind of have it playing in the background, and then you answer a few questions, and great, I got my CEUs. But like with the MBS IMP, it really does, you have to go through the 3 different zones, and when you get to like the reliability zone, like you have to get 80% on each of the components in order to pass. Like you can, let's say you only get 80% on components 1, 3, 5, and 7. Well, you don't have to redo those, but you have to go back into the reliability zone and re-rate all of the other ones. And they don't tell you what you got wrong. They don't tell you what, and they also, so there's 10 studies that you have to do. And I think they have I think it's like 15 that they rotate through. So it's not as if you're just going through and it's like, well, last time I did 1, so this time I'm going to do 2. It's they mix it up just enough that it's like, oh, okay, I have to watch this again and really figure it out. And you go back, so it really does, like I say, it hones in on the why, and it takes forever. And, but I came out of it really having a really looking at the way I did studies differently. And, we've started, we're not using the template necessarily at the hospital yet, but it, like I say, it really kind of shifted the way I was looking at studies and the way I was doing them and documenting, and really in my impressions statement, how I was putting everything forward and putting the why into words. So I've been sold on it. I came in not really sold, and then I finished it and I was like, okay, this is good.
I've heard it's tough.
Yeah, same. I've heard it's pretty intense. I haven't done it. So thanks, Brian, for taking that bullet for us.
So any other questions, thoughts, discussion points? I see Michelle wrote maybe that somewhat goes to why instrumentals aren't recommended heavily in this area. I know that in the SNF, a thought I have had is it even worth it to recommend an instrumental when I'm not going to get the info that I need to treat? That's why I'm thankful to have good mobile providers. Oh, thanks, Michelle. And more options. Yeah, I think that's a good point. I mean, yeah, why put the patient through that if you don't think that you'll get any information from it? That's a tough situation.
Mm-hmm.
Well, if that's it, I think that's all that we have for tonight, unless Brian or Ashley, you have anything to add?
No, I just want to throw out there too, you know, I know obviously all three of us are sort of swallowing focused, swallowing interested, but obviously there's a lot of other areas in medical speech pathology that aren't swallowing related, and so I would certainly be open to, you know, if we were going to have another town hall, or if people had suggestions of other topics that maybe aren't swallowing related, you know, I would certainly be open to, you know, providing whatever information or feedback or you know, education that we could.
Yeah, no, that sounds great. I do know I tend to get a little, you know, single track minded, but yeah, if anybody's got, you know, concerns regarding anything else, please, 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 we'd love to hear from you. Contact us, contact, you know, ISHA at ISHA.org. You know, for questions, concerns about anything medical speech related, we want to be here for you. We've got, you know, three of us on the board right now who are pretty darn good medical SLPs. So, you know, we want to take advantage of that and run with it and really support you guys.
Yeah. And the only thing I would add to that, I think that's great. Thank you for saying that, Ashley. You're very kind. Is if there's anything you think of that you want to hear more about at convention, please just email us. We're always open to hearing what you have to say on that, because we definitely, you know, it's your convention. We want to make sure that it's as useful as it can be to you. So. All right. Well, thank you, everybody.
Thank you.
Have a great night, everyone.